Hello there, everyone. Welcome to AIHA Awareness Day 2024. My name is Dr. Anthony Nguyen from the UC San Diego Moores Cancer Center. Today, we'll be talking about warm autoimmune hemolytic anemia and cold agglutinin disease. So, a normal lifespan of a red blood cell, whose main responsibility is for carrying oxygen to organs, is about 120 days. They don't have nuclei, and they are forming discoid-shaped cells that look like donuts. And their plasma membrane is the only structural component that accounts for their diverse antigenic, transport, and mechanical characteristics. And hemolytic anemias are classified in many different ways: inherited versus acquired, episodic versus chronic, extravascular versus intravascular, meaning outside the blood vessels versus inside the blood vessels, and they're intrinsic versus extrinsic to the red blood cells. So, intrinsic abnormalities of the blood cells include red blood cell membrane abnormalities such as hereditary spherocytosis, or red blood cell enzyme abnormalities such as pyruvate kinase deficiencies, G6PD deficiencies, and also hemoglobinopathies. Extrinsic abnormalities of red blood cell include hemolytic anemia caused by immune injury to red blood cells, such as warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, mixed autoimmune hemolytic anemia, and drug-induced hemolytic anemias. Also, extrinsic abnormalities include paroxysmal nocturnal hemoglobinuria and fragmentation hemolysis from most commonly from cardiac valve hemolysis, TTP or thrombotic thrombocytopenic purpura, DIC or disseminated intravascular coagulation, drug-induced TMAs, complement-mediated TMAs, and also hemolytic anemia due to chemical or physical agents, and also medications. Also, we have to consider hemolytic anemias due to infections, liver failure, and hypersplendism. And hemolytic anemia history for the patient. Patients often describe that they are fatigued, they have shortness of breath, which is dyspnea and exertion, lightheadedness, chest pain, chest pressure, cognitive dysfunction, changes in skin and urine color. And we also have to consider the time span of symptom development. Sometimes it can be an acute presentation. Sometimes patients have these symptoms chronically. Any family history of anemia is important. Any new medications, especially antibiotics or chemotherapies or immunosuppression, recent infections, history of red blood cell or other blood transfusions, any gallstones or history of gallbladder removal, a personal history of or family history of joint pain, rashes, and also lymph node swelling, enlarged spleen, or any B symptoms, which are fevers, chills, night sweats, and weight loss, and any history of a venous blood clot. Also, during our physical exam for hemolytic anemias, things that we look for is pallor, tachycardia, hypotension, low blood pressure, and signs of heart failure. We also look for jaundice, yellowing of the skin, and also scleroictus, which is yellowing of the eye. We also look for lymphadenopathy, swelling of the lymph nodes, and splenomegaly, increased size of the spleen. Sometimes we will also see swelling of the upper and lower extremities if their blood clot is present, and we may also see rashes or joint abnormalities when an underlying autoimmune condition such as lupus or rheumatoid arthritis is present. In our laboratory evaluation, we are suspicious of hemolytic anemia when the red blood cell survivals decreases below 100 days from its 120 days. We obtain a complete blood count with differential, meaning we look at all the components of the blood. We also see anemia, which is commonly macrocytic, which the size of the red blood cell, the MCV, commonly exceeds 100, and the reticulocyte, which is a measure of young red blood cells, which are commonly elevated. We also obtain a peripheral blood smear when we look at the blood underneath a microscope. The red blood smear underneath the microscope. We also obtain a metabolic panel and also measure direct uh, bilirubin, and we also measure other measures such as the lactate dehydrogenase and haptoglobin, which are markers of red blood cell turnover. And we also obtain a direct antigen test, which we'll talk about more later. And we also obtain vitamin measures such as and nutrient measures such as B12, folic acid, and iron panel. And commonly, when we see red blood cells, they last for about 120 days. But even sometimes in hemolytic anemias, we'll see that the red blood cell lifespan may only last 5 to 10 days. Peripheral blood smear examples, sometimes we'll see uh, spherocytes, which are red blood cells that in autoimmune hemolytic anemias that lack central pallor, meaning they do not have this um, white circle in them when they're present. So you can see that they're smaller than the average white blood cells. And this is a patient with liver failure with spurs cell anemia. So all these projections right here are consist with spur cell anemia. This is a patient with cold agglutinin disease. So these patients have IgM-bound antibodies to the red blood cells, causing agglutination, or the red blood cells stick together when they're outside the body. So this is called agglutination. So one of our common tests is, and our main test when we suspect an antibody-mediated hemolytic anemia is called a direct antiglobulin test or a Coombs test. And the principle of the test is to is is to detect antibody-coated cells. So anti-human globulins agglutinate the antibody-coated cells. There's a direct and indirect. First, we measure with polyspecific anti-human globulin that is directed against both anti-IgG and anti-complement. And if positive, these reactions are repeated with monospecific anti-human globulins to individually detect IgG and complement. So these IgG preparations recognize the gamma heavy chain of the IgG molecule. And also we have monospecific anti-complement reagents that contain anti-C3d. Binding of anti-C3d is typically indicative of a bound IgM antibody on the red blood cells. So a negative direct antigen test and a clinical laboratory finding of hemolysis that can be consistent with a Coombs negative or an atypical autoimmune hemolytic anemia. And this may be below because the IgG antibody may be below the threshold of some assays. So sometimes we do send something called a super Coombs to a reference lab. And we do sometimes have positive Coombs test without any signs of hemolysis. And this occurs in about 1 in 10,000 blood donors without disease and in 7 to 8% of hospitalized patients. Sometimes this will occur with IVIG therapy or monoclonal antibody treatment. So Coombs positive, sometimes we also classify hemolytic anemias into Coombs positive and Coombs negative. Again, like we said before, autoimmune hemolytic anemia, about 1 to 10% are Coombs negative. When we have Coombs positive, we consider autoimmune hemolytic anemia, such as warm autoimmune hemolytic anemia, cold agglutinin disease, and paroxysmal cold hemoglobinuria. Also, hemolytic disease of the newborn is under Coombs positive, and then transfusion-related hemolytic anemias, such as acute hemolytic transfusion reactions, delayed hemolytic transfusion reactions, and delayed serologic reaction. Drug-induced warm or cold can also have Coombs positive, and then there can be passive transfer antibody in immunoglobulin preparations. Coombs negative are hemolytic anemias that we talked about already, including hemoglobinopathies, enzynopathies, membrane defects, microangiopathic hemolytic anemias, drugs, um, and others. So typically in warm autoimmune hemolytic anemia, we will see an IgG that is strongly positive, and C3 can be positive or negative. In cold agglutinin disease, typically we would only see C3 positive on the Coombs test. We will also measure a serum protein electrophoresis. Which detects abnormal protein levels, evaluate for autoimmune conditions such as lupus or rheumatoid arthritis, also evaluate for hematologic malignancies, blood cancers with a flow cytometry, imaging a CT chest and also a bone marrow biopsy, and evaluate for blood clots with ultrasound, D-dimer if indicated, and a CT scan. For warm, the most common autoimmune hemolytic anemia is the warm autoimmune hemolytic anemia, and it is the most, like I said, it's the most common type of um, of hemolytic anemia, and it's estimated to be 5 to 10 cases per 1 million persons per year. The disease incidence increases with age. It's about 0.5 per 100,000 patient years in those 20 to 50 years old, and 3.34 per 100,000 patient years in patients greater than 50. It can occur with any age, but more frequently in the elderly, and the median age when patients present is typically 53, and there's a typical, usually a slight female predominance versus male. The pathophysiology of warm autoimmune hemolytic anemia is that more than 95% of patients will have an IgG antibody that binds to their red blood cells antigens independent of the temperature, and rarely antibodies can be IgA or IgM, and 5% of the CUMs are negative. These antibodies are polyclonal even in the absence of a clonal disorder. And the antibody-bound platelets, typically IgG, are presented to the spleen and bind splenic macrophages via the Fc gamma R3 receptor. And then this leads to phagocytosis or phagocytosis of the entire red blood cells and removal of significant portions of red cell membranes. And this results in the spherocytes, the small red blood cells that do not have a central pallor that we looked at. In 30 to 50% of cases, the classical pathway of a classical pathway complement pathway will be activated, and phagocytosis or eating up of the red blood cells will be mediated by C3b complement coated red blood cells. And these are cleared by the spleen and also on hepatic comfort cells. And then less frequently, the terminal complex cascade can get activated, and this form a MAC attack complex and leads to intravascular hemolysis. So these are schematics that show how IgG and complemented mediated hemolysis occurs in the spleen and also can occur intravascularly, and also IgM mediated hemolysis with complement mediated IgM um, mediated hemolysis through the activation of a complement pathway can occur in cold antibody mediated autoimmune hemolytic anemia. So the etiology of warm AIHA, 40 to 50% of the patients will be idiopathic. Secondary in other 55 to 60%. Malignancies, including lymphoproliferative disorders, will be in 25%, and most of that will be in chronic lymphocytic leukemia patients. About 25% of the secondary patients with secondary causes can be due to immune deficiency disorders, autoimmune disorders such as lupus, ulcerative colitis, rheumatoid arthritis, and ITP or immune thrombocytopenic purpura, which it would be classified as Evans syndrome. Those are patients with warm autoimmune hemolytic anemia and immune thrombocytopenic purpura. Other causes can be viral and also can be due to medications. The treatment for these for patients with warm autoimmune hemolytic anemia is for patients who are sufficiently compensated, their anemia is sufficiently compensated and asymptomatic with a hemoglobin greater than 10, we monitor closely and offer supportive care. And we monitor for symptoms that can worsen hemolysis, especially when the patient's immune system is stressed by infection, surgeries, and other medical issues. And patients with secondary warm autoimmune hemolytic anemia, like we said, from malignancies, from immune deficiency, from autoimmune conditions, should be the treatment should be directed at the underlying condition. All patients should be supplemented with folic acid since there's ongoing breakdown of the red blood cells and then a repletion of the B12 and folic acid. The goals of the therapy is to stabilize the hemoglobin to above 10, improve symptoms, and to be free from transfusion, and also minimizing the adverse effects of immunosuppression. Typically, patients who show up in the hospital with a new presentation of autoimmune hemolytic anemia or exacerbation typically require transfusions. For patients who are hemodynamically unstable, have low blood pressure, or symptomatic, we do recommend transfusions. So the antibody can cause pan-agglutination sorry, the IgG antibody can cause delay in transfusions because the panagglutinin can mask an underlying alloantibody. So transfusions may worsen the hemolysis. So asking the patient about prior blood transfusions, pregnancies, miscarriages is crucial. Um, and then ABO matching, which we can do, avoids ABO incompatibility. If there's ABO incompatibility, the transfused blood will be hemolyzed, similar to what's going on for the patient. So the every every unit that we seek to match with the patient will be incompatible. However, um, However, we the blood bank will try to match as close as we can, and for patients who are hemodynamically unstable or symptomatic. So the treatment for after the patient stabilized, the first line of treatment is corticosteroids. Typically, we start with prednisone, 1 to 2 milligrams per kilogram per day for 2 to 4 weeks until the hemoglobin is greater than 10, and the hemolysis markers such as the LDH and haptoglobin and bilirubin improve, followed by a prolonged taper to the lowest effective dose. Um, the response is very promising in 85% of patients. However, when we taper the steroids, 50% of patients will relapse within 3 months. Um, and and 2 out of 3 patients with steroid who respond to steroid require additional treatment. And there is many side effects to steroids. And in patients who don't respond to steroids or patients with severe disease, we do consider adding rituximab. And rituximab is a monoclonal antibody against CD20 that is targeted at B cells and is used in patients who are resistant to or dependent on steroids. First, we must screen for hepatitis B, and the standard dose of rituximab is 375 milligrams per meter squared for 4 weeks. And studies in the past have shown that rituximab with steroids elicit a much higher response than with steroids alone. Other treatments can be splenectomy, where we remove the spleen. The response rates are very high, 70 to 80%. It can be considered if medical therapy with steroids and rituximab are not effective, and if a splenectomy is performed, immunization against encapsulated organisms such as pneumococcus, H. influenzae, and meningococcus are recommended. And then patients can have severe infection after a splenectomy, and this can occur years or decades after procedure. And for after 1 month after splenectomy, a patient should be started on blood thinners to avoid deep vein thromboses. So here's an outline of the first and second line treatments. As we mentioned, glucocorticoids or steroids are typically our first line. Typically, we try oral steroids initially so that patients can be sent home on oral steroids. However, there are many adverse effects from steroids, including diabetes, osteoporosis, infections, hypertension, Cushingoid syndrome, mood swings, and the long-term remission rate is only 20 to 30%. Rituximab, which we talked about, is as a monoclonal antibody against CD20 and B cells, and that's typically 4 weekly doses, and the response rate is 80 to 90% after for 3 to 6 weeks. However, there are risks of reactivation of B infection that we may consider. Selenectiny, which we talked about, does carry its own infection. IVIG is another way to introduce immunoglobulin. It has a very quick time of response, about 1 to 5 days. However, there are side effects such as aseptic meningitis, renal insufficiency, and it in of itself can cause hemolytic anemia. However, the responses are very transient, and the rest of the second and third line treatments are really stronger immunosuppression for patients. Other considerations of why AIHA is that patients do have an increased risk of developing lymphoproliferative disorders, and they're also at increased risk at developing blood clots, and this can occur in 11 to 20% of patients. And blood clots usually manifest in with deep vein thromboses, and arterial thromboses um, can also occur too. Patients who do have warm autoimmune hemolytic anemia do have an unreliable A1C due to chronic hemolysis. So this is a schematic of how we think of how we work up, and also how we think of hemolytic anemias after we get the direct antigen test or the Coombs test. So this is another schematic of where we can use different types of drugs and different types of inhibitors in order to decrease hemolysis in patients. And this is sutimlimab is one medication we'll talk about later in this presentation. However, we already talked about corticosteroids, splenectomy, and IVIG for warm autoimmune hemolytic anemia. So there are several clinical trials looking at to improve the outcomes for patients with warm autoimmune hemolytic anemia. One of these trials is a phase 3 trial looking at a medication called obexelimab. So obexelimab is a FC engineered humanized bispecific antibody that targets CD19 um, that that leads to the inhibition of the function of B cells that ultimately produce these IgG antibodies. And patients typically have been diagnosed with WAIHA at least 3 months and currently receiving treatment for WAIHA. And the patients must have failed at least one other prior WAIHA treatment regimens, which can be steroids, rituximab, and also other immunosuppressions. Um, so the primary endpoint of this study is to determine the proportion of patients who retrieve a durable hemoglobin response, defined as a hemoglobin greater than 10, um, and also an increase of greater than 2 from baseline. So this study has two parts of the study: a safety and dose confirmation period, and then later on, once enough patients are enrolled, a randomized portion where patients receive obexelimab, which is a subcutaneous injection versus placebo. Another medication is or study um, is a phase 2 study looking at a drug called pulvo, povetacicept in patients with warm autoimmune cytopenias. And it's called the Ruby 4 trial. And this study includes patients with ITP as well as cold agglutinin disease as well as warm autoimmune hemolytic anemia. Just like the last study, the diagnosis of WAIHA must be at least 12 weeks before, and the patient's hemoglobin needs to be less than 9. And however, in this study, the patient must have failed or relapsed after at least two treatments for WAIHA. So the povetacicept is targets the APRIL BAFF antagonist that modulates B lymphocytes and also pathogenic autoantibodies. So APRIL and BAFF are key drivers of autoantibody production in B cells. So povetacicept neutralizes both BAFF and APRIL that leads to decreased pathogenic antibody production that will hopefully decrease hemolysis of red blood cells. And one other study is another phase 3 study of a drug called ianalumab in patients with warm autoimmune hemolytic anemia. And this study is looking for patients who failed at least one line of treatments for WAIHA. And the ianalumab it is similar but has a unique mechanism of action. It's similar to the last experimental drug, which this drug blocks the BAFF receptors and also depletes B cells. So again, all these three drugs, all these three trials are in development, and in terms of ianalumab, there are three arms of treatment. One arm is ianalumab 3 milligrams per kilogram. Another one is 9 milligrams per kilogram, and the arm C is comparing it to placebo. So next we'll move to cold agglutinin disease. So what is cold agglutinin disease? Cold agglutinin disease is a condition where cold reactive autoantibodies bind to red blood cells at a temperature of less than 37 degrees Celsius. And usually it's due to an IgM antibody, and due to its pentameric conformation, these IgM antibodies can span the distance of several red blood cells to cause agglutination or red blood cells to stick together, as we saw in the peripheral smear. When we measure the cold agglutinin titer, a titer of 1 to 64 is considered clinically significant. And then we also obtain something called the thermal amplitude. It's the highest temperature at which cold agglutinins react to cause agglutination or sticking of the red blood cells. The mechanism behind cold agglutinin disease is fixation of complement and clearance of C3b cells by attachment to complement receptors in macrophages in the spleen and the Kupffer cells in the liver. And this can also lead to direct lysis of red blood cells by the terminal complement sequence. And in terms of cold agglutinin disease, that it's usually primary idiopathic, meaning we don't know what the cause is. Sometimes clonal B cell proliferation may be detected in the bone marrow or the peripheral blood, but however, we do not find an evidence of lymphoma. Sometimes we'll find that patients have an extra protein called an IgM kappa protein in up to 90% of cases. And the cold agglutinin disease, just to review again for how it mediates hemolysis, is that in temperatures less than 37 degrees, IgM antibodies bind red blood cells and mediate C1, C2, C4, and C3 convertase function. And this leads to complement activation. Then when the when the temperature is warm up to 37 degrees, cold agglutinin IgM detaches from the complex, and the red blood cells separate. However, the C3b remains bound to the red blood cell. Then C3b bound red blood cells, they're sequestered or trapped by by the liver and the spleen and undergo extravascular hemolysis in the liver and the spleen. And the complement pathway can also proceed beyond C3b and lead to C5 through C9, and that this causes intravascular hemolysis. So another condition, which is a cousin, I think of it as a cousin of cold agglutinin disease, is cold agglutinin syndrome. Typically, cold agglutinin syndromes are due to underlying conditions such as infections, autoimmune disorders, and lymphoid malignancies. Infections are typically self-resolve. They include mycoplasma, pneumonia, infectious mononucleosis, and viral infections. Autoimmune conditions, we typically see lupus, rheumatoid arthritis, and lymphoid malignancies are comprised of lymphomas, CLL, Waldenström macroglobulinemias, and other lymphoproliferative conditions. The cold agglutinin disease treatment, the primary treatment with or without a low-grade bone marrow lymphoproliferative disorder is treatment is reserved for patients with symptoms. And the symptoms include symptomatic anemia, fatigue, or cold-induced ischemic symptoms that are interfering with daily life. Many patients will say that when they go into the cold, their hands actually feel cold and also have discoloration. Treatment for patients who are symptomatic are aimed at clearing out the pathogenic B cell clone with rituximab-containing therapy, other medications called bortezomib and ibrutinib. If anemia is mild and patient is asymptomatic, that no treatment is needed. Typically, we tell patients to avoid cold temperatures. If transfusions necessary or IV fluids are necessary, we would we would recommend transfusion through a blood warmer, treat the underlying condition. and supportive care this is caused by infectious etiology. We do know that steroids and splenectomy are not effective in cold agglutinin disease and cold agglutinin syndrome. So when we think about choosing therapy for cold agglutinin disease, we think about whether the patient is how fast we need a response and the patient's symptomatic. So when we think about if the time needed for response is quick, meaning the patient had an exacerbation that needed an immediate treatment effect, we think about using complement inhibitors. If it's due to circulatory symptoms such as acrocyanosis or discoloration of extremities. We think about B cell reductive therapy like rituximab. And so sutimlimab is a medication that was approved in 2022. Sutimlimab is a drug that is subcutaneous drug that selectively targets complement C1s, and when we target the proximal part of the complement cascade, this prevents patient prevents the complement system and pathway from being activated. So the complement pathway that leads to extravascular as well as intravascular hemolysis is not activated. And the study that led to the approval of sutimlimab randomized patients in a 26-week period to sutimlimab versus placebo. As you can see, the mean hemoglobin improved with sutimlimab from week 0 to week 26, and there was an early sustained response in anemia, hemolysis markers, and fatigue. Currently, the guidelines on the risk stratification of cold agglutinin disease, when we find that the patient has cold agglutinin disease, if they are asymptomatic or very mild symptoms, we actually continue to advocate for a watch and wait approach. If the patient has a trigger or has an exacerbation that causes a profound anemia and a rapid response is needed, sutimlimab is recommended. For patients who have symptomatic anemia, fatigue, bothersome circulatory symptoms, there is indication for treatment. If the circulatory problems such as acrocyanosis is prominent, we can consider sutimlimab. However, typically we would advocate for rituximab containing regimens such as bendamustine with rituximab, rituximab alone, or even a clinical trial. If there is a response to B cell directed therapy, is we watch and wait. If the patient fails, we can consider ibrutinib, bortezomib, or a clinical trial. Um, for um, um, for patients who do start sutimlimab, we would continue sutimlimab indefinitely or transition to a B cell directed therapy. Um, so in for patients who don't have circulatory symptoms that are prominent, we also use B cell directed therapy. Again, bendamustine rituximab in fit patients. In frail patients or older patients, typically we would consider single agent rituximab. And again, we proceed if the patient we proceed according to how the patients respond. If the patient responds well to rituximab, we watch and wait. If patients fail, then we that we if patients were treated with rituximab, we watch and wait for a late response. However, if the patients have a clear failure, um, um, we may consider other B cell directed therapies like ibrutinib, bortezomib, or a clinical trial. And we also may consider sutimlimab if it was not previously given. So emergent treatments, there are emergent treatments, and just like the other studies that we talked about for warm autoimmune hemolytic anemia, there povetacicept, again target the APRIL and BAFF antagonist, is in a phase 1b for the Ruby 4 trial, and then another phase 1 trial looking at anti-C1 humanized antibody is also in trial for cold agglutinin disease. There are phase 2 and phase 3 trials using a drug called pegcetacoplan, which is an anti-C3 antibody. This drug is currently approved for paroxysmal nocturnal hemoglobinuria, but this anti-C3 antibody is currently in clinical development for cold agglutinin disease, and then also a phase 2 study using a drug called iptacopan, which is a small inhibitor of complement factor B, is also in clinical trials. And again, this is our schematic of how we diagnose diagnose and the pathway to the diagnosis of warm versus cold hemolytic anemias. So again, this is another, I think, a very useful summary chart of the incidence, the cause, the pathogenesis, and the typical findings in terms of the workup of warm and cold hemolytic anemias, and then secondary cold agglutinin syndromes. Please reach out to me if you have any questions, or reach out to one of the AIHA Warriors staff. Thank you, and have a nice day.